I'm going to talk about osteomyelitis, which is bone infection, acute and chronic, and septic arthritis, which is the joint infection. These are very important to understand their clinical importance, and they are considered red flags. So how can infection spread? It can spread by blood. Bacteria will be transmitted through the circulation from one place to another. Can spread from the adjacent soft tissue or from direct implantation secondary to trauma or surgery or open fracture. So usually infection starts in the intermedullary canal, especially the metaphysis, because there is the circulation here is not very active, so there's stasis here. And then when the infection happens, starts in the intermedullary canal, starts penetrating the cortex, accumulating underneath the periosteum, then eventually, it will escape to the subcutaneous tissue, then to the skin. Something called sequestrum and involucrum. Sequestrum is dead bone, involucrum is a new bone forming around it as a repair mechanism. And these are some x-rays that shows some new bone formation, which is on the outside, and the dead bone in the middle. So to diagnose patient with infection, you have to do history, physical examination, blood test, images, and reach differential diagnosis by obtaining tissue cultures, or reach the definitive diagnosis by obtaining tissue cultures. So generally, pain, fever, malaise, restlessness, loss of function, inability to use a limb, local swelling, increase in temperature. Sometimes a patient will have characteristic position like abduction and flexion, or external rotation and flexion of the hip. And this indicates hip infection, osteomyelitis around the hip joint, or more commonly septic arthritis in the hip. And this position will cause relaxation of the hip capsule. Therefore, patient will feel relieved in this position. So acute hematogenous osteomyelitis, usually transmitted by blood, more common in children, boys more than girls, more common in long bones, metaphysis, because there is some stasis there, lower extremity more common than upper extremity. Should do CBC, ESR, CRP, blood cultures. In the CBC, the white count will be high, polymorphs will be more than 60%. ESR, CRP, they're good for monitoring the response of treatment. Blood culture is only positive in 50% of cases. Imaging, you can start with plain X-rays, but it will not show any bony changes before 2 weeks, but you can see some soft tissue changes. Ultrasound also might be helpful in diagnosis soft tissue involvement. Bone scan is very helpful, especially when you add gallium to it. It just tells you where are the areas of increased uptake and more blood flow. MRI is very important to diagnose osteomyelitis. And sometimes you need to do it under sedation or anesthesia, especially for the pediatric patients. So these are plain X-rays showing no bony changes, but some soft tissue swelling. This is how the bone scan appears. You can see on the left side of the patient, there is increased uptake in the distal femur. Again, these are some examples of active bone scan. MRI is very important, as we see here. It shows you all the lesions, soft tissue collections, edema in the bone marrow. So differential diagnosis, usually acute septic arthritis, cellulitis. Always remember to put tumors with infection in the differential, so Ewing sarcoma. Sickle cell crisis, also acute rheumatoid arthritis, can have similar presentations, so you should keep this in mind. So how to confirm diagnosis? You need to take a sample before you start antibiotics, and then analyze it, send it for culture sensitivity, aerobic, anaerobic, TB, fungal testing, and also histopathology examination. So once you diagnose patient with osteomyelitis, should be admitted, given adequate hydration, pain relief. Broad spectrum antibiotics is started after obtaining material or culture or sending blood cultures when there is fever, because you don't want to give antibiotics and obtain a culture or obtain a sample, because that sample will be misled by the bacteria might be masked by the antibiotics that the patient just received. Histopathology is very important to confirm diagnosis. Empirical antibiotics should be started as soon as the patient is diagnosed and the cultures or the samples are taken. This empirical treatment depends on suspected organism according to age and other circumstances. So usually this can happen in newborns, young or adult patients. Also, presence of other circumstances like sickle cell disease or hemodialysis or drug addict can influence the choice of antibiotics. In sicklers, Salmonella is a characteristic organism. However, it's not the most common, since the most common is always Staph aureus. You can give fluoroquinolones, and also you can give third generation cephalosporin, especially if you suspect Staph aureus. To make it simple, Staph aureus is the most common organism. The empirical treatment should be oxacillin or third generation cephalosporin, except in sicklers, you should consider giving fluoroquinolones. Depending on the result of the culture or isolated organism, you should change your antibiotics, and after consulting the ID team. When do you consider surgery? If there is no response to the medical treatment, or if there is fluid collection, you have to drain the pus and the fluid. So this is the most important indication for surgery. Then once you do the surgery, you need to localize the lesion that you need to debride. Sometimes X-ray guidance is helpful. So you have to decompress any collection or pus, debride the bone, remove dead bone, and then leave a drain inside. Sometimes you should leave some antibiotics locally, and this can be delivered by making some pellets made of cement or small patches of cement mixed with antibiotics, just to allow it to be released for a period of 2 to 4 weeks. Post-op, continue IV antibiotics, make sure it's changed according to the culture. Follow up with ESR, CRP, and CBC, repeat plain films and other images like CT and MRI. Long-term follow-up to exclude complications is very important. Complications like septicemia, abscess, septic arthritis, growth disturbance in skeletally immature patients, pathological fracture, or chronic osteomyelitis. These are examples of, complications of osteomyelitis. You can see here the infection affected the growth plate. Here we have pathological fracture with a crack through sequestrum or the dead bone. Same thing on the far right. So chronic osteomyelitis is common in inappropriately treated osteomyelitis, also in patients who underwent significant trauma or patients who are immunocompromised. So there is this classification based on anatomy. So there is superficial chronic osteomyelitis, there is medullary, there is localized, including the medullary canal and the cortex, but it's only in one area, and there is diffuse, which is involving most of the intramedullary canal and cortices all around. So almost similar presentation to acute osteomyelitis, except the hotness and redness is less. There's usually sinus tract, and you have to be careful and watch for squamous cell carcinoma and around this tract, especially if it's a chronic. These patients usually will have periods of quiescence, which means the silence of the disease, and then after that they will have flares up. As we mentioned, so images can help, especially nuclear scan to see the activity of the disease. And don't forget to take a sample to know exactly what you are dealing with. So empirical therapy is not indicated because you need to get deep cultures first. Most common organisms, as you mentioned, Staph aureus, and then E. coli, and then P. aeruginosa. If you have chronic osteomyelitis in the presence of hardware, this hardware needs to be removed because the bacteria will form a glycococcus envelope, which is formed of polysaccharides, and that envelope or coating will prevent antibiotics from reaching the organism. So you have to remove the implant and make sure that this is not causing resistance of response to antibiotics. So as we mentioned, the debridement is very important. Remove all hardware, dead bone. Once you do this, there will be some voids you need to fill with cement initially and antibiotics till the infection has eradicated. After that, you need to apply bone grafts, soft tissue coverage. In certain cases, amputation might be the end result, especially if the infection is persistent and not responding to your treatment. So this is how you debride the bone. Make sure you remove all the dead tissues. And then continue following up the patient for any recurrence or complications, just like in acute osteomyelitis. Septic arthritis is infection of the joint. Can affect any age, any joint. Knee and hip are most commonly affected. Transmitted by blood or from bone. It's very important to understand that in neonate, there is still some vessels penetrating from the metaphysis through the physis to the epiphysis. So this can lead to transmission of osteomyelitis to the joint and causing septic arthritis. And also in joints where the metaphysis is intercapsular, like the hip, shoulder, proximal radial joint, distal fibula. Also, you have to consider this as a risk of transmitting osteomyelitis from the metaphysis to the joint. So this illustrates what we just explained. So symptoms like acute osteomyelitis, but sometimes joint swelling is more pronounced. Limits the range of motion is also a very important thing to look for. Inability to bear weight. Joint is fixed in a position of ease. Just like in this case, both hips are externally rotated and flexed. Same investigations. In this case, you can do joint aspiration. If it's more than 50,000 with more than 90% polymorphs, then this indicates septic arthritis. Organisms are similar to the acute osteomyelitis. Most common is Staph aureus. So usually once you diagnose a patient after taking a sample, empirical antibiotics, emergency arthrotomy and washout of the joint. And splinting the joint is very important because sometimes septic arthritis and joint effusion can cause instability. Main differential diagnosis, especially in pediatrics, is transient synovitis. The only difference between them, transient synovitis will respond to NSAID and will improve within 24 hours. This is how we do the aspiration of the knee, and there is special seminar about this. So differential diagnosis, as you mentioned, transient synovitis is most important, especially less than 10 years old. Acute osteomyelitis, reactive arthritis, vasculitis, traumatic hemorrhagosis, and hemophilic arthritis. Drainage is very important, either by scope or open. Joint should be cleaned thoroughly and drain left in place for a few days till all the fluids are out. And remember, don't forget to give the IV antibiotics for at least 4 to 6 weeks. Complications, septicemia, abscess, osteomyelitis, joint destruction, joint subluxation or dislocation, ankylosed joint because of damage, avascular necrosis of the femoral head, growth disturbance. Okay, so now we're going to talk about bone TB. There's a chronic bone infection, may affect any age. Cause of organism is Mycobacterium tuberculosis. It's an acid-fast bacilli, can be diagnosed sometimes by direct smear. When bacilli is seen, it is diagnostic of TB. It takes sometimes up to 6 weeks to grow in culture, so you have to be patient. Endemic in poor, underdeveloped countries, still present sporadically at Saudi Arabia, especially from immigrants and workers from outside. In developed countries, TB patients are immunocompromised patients like AIDS patients or drug addicts or immigrants. So histopathology is very important to confirm diagnosis. When you see acid-fast bacilli, also see Langerhans giant cells, and also cessation is also present in the histopathology slides. The presence of lymphocytes and monocytes. These are some. This is a slide showing that what we just illustrated. So TB in the spine, it calls pod disease, or POTS disease, affects any part of the spine, most commonly dorsal spine, which is the thoracic spine, can lead to dorsal kyphosis. Famous for causing psoas abscess and paraspinal abscesses. TB spinal abscess might compress spinal cord and cause paraplegia. This is how the dorsal kyphosis look like in POTS disease. So infection spreads to adjacent level under longitudinal ligaments and through the blood. Eventually, a kyphosis deformity will occur. Paravertebral abscess is common and might be distant as well. So cervical, more than cervical will cause retropharyngeal abscess, and lumbar involvement will cause psoas abscess. Compression at the spinal cord is more likely to happen at the thoracic level. In POTS disease, neurological deficit occur due to compression secondary to the deformity or compression from the abscess. Paraplegia might occur, reversible if treated early, mostly treated non-surgically. This is an MRI showing POTS disease in the dorsal spine with the classic deformity and fluid collection. Here also you see this is a psoas muscle, and you can see there's some collection inside. So the main characteristic radiographic appearance, erosion and destruction of the end plates, narrowing of disc space, soft tissue mass, shadow anterior wedging of the vertebra, kyphosis, deformity. So to confirm diagnosis, you need to do some special tests, tuberculin skin test, spine CT-guided needle biopsy of the lesion. If you have joint involvement, you should take synovial fluids or get samples from the bone and soft tissue. Send this for aerobic, non-aerobic bacteria, fungal, acid-fast bacilli, enriched culture media. You should leave it for a long time as it can take up to 6 weeks. So TB in the musculoskeletal system in general is secondary to TB in the lungs. Famous symptoms: fever, malaise, weight loss, night sweat may not be present these days. However, you should look for it. Suspicion of disease, previous history of TB, presence of osteopenia, and loss of joint space. So this is an X-ray of the right hip that shows classic radiographic signs of TB, which is erosion and osteopenia. Treatment is non-surgical by triple or quadruple drugs, isoniazid, rifampicin, ethambutol, and pyrazinamide. Drug therapy to continue up to 1.5 years. Surgery in TB is only done when you have abscess or to decompress spinal cord, or if there is instability of the joint or the spine. RAS pathology is brucellosis. Milk and milk products is a source. Now less incident in Saudi Arabia due to milk pasteurization and awareness about not consuming unboiled camel milk, back pain and stiffness, muscle spasm, fever. Sacroiliac joint is the most commonly involved, less destructive than TB. You should check the Brucella titer. It's diagnostic if it's more than 640. Antibiotics is spectrin or oxytetracycline. And then mostly the treatment is medical. So now we come to the end of this lecture.